I have to two-hand this tonight. This is my pointer and obviously the mic. So as everyone can see, incontinence, no laughing matter, whereas this is my subtle attempt at humor. It's also a pretty serious statement. You know, for some people, incontinence can be something where it's just a little bit of dribbling or an inconvenience. For other people, it could be actually very debilitating and something that prevents them from engaging in any number of things in life. So again, all laughing aside, that is actually a pretty serious statement we're here to talk about today. So first thing here, always got to start a presentation with somebody that's smarter than you. So we went with Mark Twain here. Against the assault of laughter, nothing can stand. So some people might think he's talking about the commonality of man and how laughter can unite us. Really, I think he was talking about incontinence the whole time, so very pertinent to this venue. The basic structure of how I'm approaching much of this talk is basically based on what are questions that you all come in and ask me when you come to see me. You know, what are the things that you will bring up? What are the things that you really want me to address, and kind of approach this talk from that standpoint. And it's kind of a 10,000-foot view of incontinence, since we're going to wrap it up in about 20 minutes. With that, I'll get started. So first question is, am I the only one? So a lot of people don't really love talking about this topic. They don't love talking about it with their friends or their family or anybody else. So for some people, this is something that is very isolating, and is also isolating in the sense that when the incontinence is really bad, it's hard to get out and do things and engage in life. So that question, am I the only one really suffering from this, frequently comes up. And the answer is absolutely not. Unfortunately, this is much more common than we really want it to be. As far as the general population, about a third of women deal with incontinence, and it's one of those things that increases as we get older. So, you know, around age 50, probably 40 to 50% of women are dealing with some facet of incontinence. By the time you're 75, it can be as high as 75%. So this is actually something very common, probably something obviously all of you know somebody that's dealing with this if you're not dealing with this yourself. This costs about $20 billion a year to treat. So just to put it in perspective, that this is a big problem. A lot of people suffer with it. Second question here, is this just part of getting older and having kids? I actually hear this one quite a bit, you know, in the sense that, is this just part of the martyrdom of motherhood? You know, is this the sacrifice that you made for your kids that now as a result you just have to bear this burden? Now, when it comes down to it, it really comes down to two questions that people are asking me with this one question. So the first is this normal? And I think we already covered that this is actually quite common. I don't know that I would put it in the realm of normal in the sense we should just have to accept it and deal with it, and this is how we just have to function throughout life. No, it is not normal in that sense, even though it is common. Which again, it comes to the second question, do I just have to accept living with this? Is this just the consequences of decisions or choices I made in life, and this is just the natural ramification of it? And the answer is absolutely not. You know, I wouldn't be here having this conversation in general if we just had to accept it. I mean, there's lots of ways to do it. This isn't some burden you just have to bear. All right, so now we get to causes, okay? There are a lot of causes for incontinence. I frequently encounter the issue where people come in and they think incontinence is really one issue. I just have incontinence, and frequently will even come up, oh, you saw a friend of mine and you did this, I want what she had, okay? That is actually really common. Well, in truth, what you have going on might not be what she has going on, and what she had done is actually not the most appropriate thing for you. So there's a laundry list of things that can cause incontinence, and I kind of broke it down into three main categories here. All right, here we're going to try my fancy new pointer. Oh, there we go. So one being urinary retention, one stress urinary incontinence, and one urge urinary incontinence, okay? Despite many of the causes of incontinence, like different neurologic issues, diabetes, things like that, usually we can break it down into one of these three main facets that is really impacting and approach it from that aspect. Okay, so urinary retention, pretty self-explanatory. Your bladder is not emptying as well as it should, and you are retaining urine on a chronic basis, which can then lead to overflow. Stress urinary incontinence actually has nothing to do at all with stress. That is the kind of incontinence you get when you cough or sneeze or laugh or lift. It's the reason you can't jump on trampolines anymore. So it's a basic issue where abdominal pressure pushes down against the bladder. That pressure against the bladder makes it dribble a bit, okay? The last issue, urge urinary incontinence. So this is the kind of incontinence that people experience like, oh, I've been sitting in a chair and watching TV doing fine, stand up and, oh my God, I can't get there fast enough. Or, oh, I hit my garage door opener and as soon as that garage door is going up, my bladder is going with it. So that is classic symptoms of urge incontinence. One thing I put down here is try my pointer again. So as the myth, and I'd say this, it's not an absolute myth, but I think it's commonly a misconception, probably is a better statement. So there are plenty of times that I encounter a circumstance where someone comes in and their chief complaint, the thing they mentioned very first is, I think my bladder's fallen. When we really break down what's going on, they don't have symptoms necessarily of their bladder falling, they have incontinence issues. And the two are not the same thing. You can have them very separate. Now, prolapse, things falling, can very much act on incontinence. It's not necessarily the cause. For instance, even if we repair incontinence, repair prolapse, sometimes we'll see that incontinence worsen. Getting water. Needed to drink more apparently today. So one thing that we have to really address in clinic then is like, okay, if we're approaching like a true fallen bladder and we're talking about one of the like tack-up procedures, that yes, I am treating that aspect of that, but I cannot necessarily assume that treating your prolapse will absolutely correct the incontinence. And there are frequently things we have to do to separately address that as well. I know I'm getting a lot of side eye right now, it's okay. I'm used to that aspect. All right, so I'm going to break down some of those three main causes in a little more depth here. Okay, so first thing on back to my pointer. Okay, so first thing we'll talk about is this urge urinary incontinence on the left. Okay, urge urinary incontinence I like to think of as a functional cause of incontinence. Okay, your bladder's job is to store urine. When it doesn't store urine the way you want it to and you develop incontinence, it is leaking, correct? So when we all go through potty training, when we're 2 to 3, your brain develops an inhibitory function on your bladder. You know, your bladder triggers a signal that, hey, I've gotten something in here to go. Your brain has then learned to control that. It basically hits a pause button on your bladder, okay? When you develop urge incontinence, the problem is that pause button is no longer working, okay? So you can see that for a lot of different reasons, different neurologic issues, spine issues. You know, there could be some nerve damage secondary to problems with deliveries, but a number of things contribute to it. But what happens, once you lose that inhibitory function of your brain on the bladder, you get a reflex reaction. Think of it like a knee jerk, okay? In the sense, you tap the knee, your leg jumps, right? Problem with urge incontinence is you tap the bladder empties. And so it's that hair trigger that fires that you then can't control anymore. Okay, so all of that complicated stuff you see is basically breaking down. Well, so this area on the right talking about, okay, you got sensory receptors in the bladder. Your brain can then control it through this, what's called the micturition reflex in the pontine micturition center, versus this area over here, which is just this uninhibited reflex. So trigger signal fires, goes to your tailbone through the sacral nerve, immediate reflex to empty your bladder. Okay? Next thing is the stress incontinence. So I know everyone's looking at that going like, what the heck is going on with all those arrows? It's like airplane. What's the vector, Victor? Biggest things here, back to my pointer. So obviously that's your bladder. That tube portion of it right there is the urethra. Okay? See this H, this blue sheet? That H stands for hammock, which is a combination of one, this pubourethral ligament, and then some other muscles and fascia in that area. Essentially what happens is when you push down on the bladder, that same force is applied to the urethra. Okay? When that force is applied to the urethra, it goes into that hammock, pinches off, and you don't leak. When that hammock is no longer working correctly, you develop stress incontinence. There's nothing for it to pinch off against anymore. So in that sense, whereas urge incontinence is a functional incontinence, stress incontinence is more anatomic. There is something physically weak, something that is physically broken. All right. Last thing here is pretty easy to understand. Overflow incontinence. So that's that urinary retention component. So bladder doesn't empty well, chronically isn't emptying well, and it basically gets to a situation where the pot then is just too full. Too much pressure, little things then will just make you go. And sometimes symptomatically this is hard to discern because people with overflow incontinence will come in and say they have to go to the bathroom all the time, they're up all night going pee, and then the littlest things make them leak, which sounds like urge incontinence. On the same sense, they'll come in and tell you, oh, by the way, when I cough or sneeze or jump, I'm also leaking, which sounds like stress incontinence, when in truth the whole time could be that their bladder is just so physically full that it doesn't take any provocation to make it leak. And it's until we really evaluate that in clinic that we can't discern that as well. All right, so next question. Is there something that you can do yourself? What are the things that you don't need a doctor to do or help you with to figure this out? So one, diet. I'd say biggest thing is some of the fluids. The people that I love to come in and treat in clinic are the ones that say, I ask them what they've been drinking and what their caffeine intake looks like. They say, I drink sweet tea all day. Those people, if I can convince them to actually stop their sweet tea, we'll probably see a big improvement in their incontinence. So what you're eating and drinking, particularly things that are going to stimulate or irritate your bladder, can be a big difference here. Exercise, and this isn't exercise where I'm just talking about you being fit as a fiddle. You know, this isn't you like rowing for an hour, then running 10 miles, and then doing weights after that. Okay, I'm getting more specific to pelvic floor exercise, and you know, we use physical therapy a lot in this realm to do that. The device I actually have over here, this one's a prescription, but you can get ones that are not prescription. It's basically a monitor you can place in the vagina to help you do those exercises. So it links to your phone, basically guides through exercise regimens to help with the pelvic floor exercises. So if for some reason we can't access a physical therapist, this is another way of trying to accomplish some of that. Weight management is also an issue here. It's simply just the more pressure you put against the bladder, the more prone it's going to be to leak, almost regardless of which type of incontinence we're dealing with. Diabetic management, also a big issue here, and I'm talking about both acute management as well as chronic issues. Acute management because the more sugar that is in your blood, you know, the worse the diabetes is, the more sugar you're spilling into your urine, the more urine you physically make, which will then worsen incontinence. Because where the sugar goes, it drags water with it. Okay? That's why, like, say people that are newly diagnosed diabetics, one of their chief complaints are like, I'm thirsty all the time and I pee all the time. Well, that's because they're losing so much fluid from urination. Okay? Chronically, though, the impact of diabetes can affect blood flow and nerve function. I mean, if anyone has diabetes, you know, they do the testing on your feet to see how well those nerves work, right? Your bladder has nerves to make it work too. Chronic diabetes can impact those and lead to then urinary incontinence. And so it's both an acute and a chronic problem as far as why you can have incontinence with this. Constipation, sorry, is actually an important factor here as well. One, sometimes that's just an evidence of some of that nerve dysfunction. Two, your pelvic floor is a bowl. That bowl is only so big. If you have other things in that bowl, it then makes it more difficult to, say, have a bladder that's going to store much urine. If that bladder already has a hair trigger or leaks easily, well, that's the release valve on that pressure. So people that have constipation issues frequently have a harder time with incontinence. If I get a 17-year-old in my office that's complaining of urinary frequency and incontinence, constipation is probably one of the bigger factors. Because usually their nerves, typically don't have a lot of dysfunction as far as neuromuscular function. it's usually, okay, how much is in that bowl? And they can have some significant constipation issues. They're then like, oh yeah, that's why you have to pee every hour. The last thing I put on here, poison presses. Those sometimes can be handy. They're not a cure-all, but this is the kind of thing, it's basically like a bulkier tampon is probably the best way to describe it. You place it inside the vagina. It has an area below the urethra that has a little more bulk and can put a little bit of pressure there. So particularly for stress incontinence, it might be one of those like, oh, periodically if I want to go to the gym and not have an issue, it might provide just enough that it lessens the incontinence. And those are available over the counter. All right, so this is an anxiety-provoking thing. What happens at the visits? I can't count the number of times I've had people say how nervous they are coming in to see me because of what might happen and they don't know what's going to happen. Generally speaking, this is simple. The first thing we do is just talk. Probably 75% of me figuring out what kind of incontinence we're chasing is based on the words coming out of your mouth, okay? 25%, or not, probably not that actually, 15% will say is the exam, okay? Taking a look, seeing what's the quality of the vaginal tissue. Do I see other physical findings of, say, stress incontinence where that hammock is not holding well? Is there prolapse issues? Are there other masses present? All right. From that, we could move on to diagnostic testing, and that could be a couple different things. Sometimes it might be some imaging modalities depending on what's happening. Sometimes it might be this fun little machine that I have the picture of behind me. That's a urodynamics machine. Basically, with this machine, I can test your bladder to see functionally what is happening in the office that maybe is not clear based on me talking to you and just looking. So not everybody has that test. That test I do basically if I'm too dumb to not figure out what it is from talking to you and looking, okay? Because it has catheters with pressure sensors. I can fill up your bladder. We can provoke things to see what makes you leak. It has monitors to check muscle function, so I can look at much more nitty-gritty about, okay, what factors are contributing to you leaking, and particularly complex pictures where it's not just one factor. And I'm trying to figure, okay, what is going to give us the most bang for our buck as far as when we start treatment? That can be helpful. And that's usually a separate visit. Okay? So usually, big point, it is pretty simple. Not tons of diagnostic tests. It's mainly just me figuring it out from history and physical. All right, start getting into some treatment options here. So stress urinary incontinence, like I said, is more anatomic as far as its approach. So what you see on your left there is a mid-urethral sling. Basically, we started using this style of sling around 1995, and really the guy that developed it was the guy that came up with that hammock hypothesis. He did pressure sensing along the urethra, and whereas before him, everyone thought, oh, it's primarily at the neck of the bladder where the sphincter muscle is that keeps urine in, he actually figured out, no, it's in the middle of the urethra. It is not that sphincter muscle. And then figured out, oh, this combination of tissue right here is what's actually preventing people from leaking. Why don't we do something at that spot to correct it? That's about an 85% fix for incontinence. So if we have light switch fixes for incontinence, that's probably the closest thing we have to it. Because that's one of those things I can have someone who is having a lot of issues with stress incontinence, can put that in, and then it's better right away. It's not one of those things that usually takes weeks to set up, okay? Over on the right side here is a urethral bulking procedure, okay? So back to my, oh, here we go. So that's the bladder. That's the urethra right here, okay? The blue is some of the bulking material. It's a gel. And we've used lots of stuff over the course of time, but this is like a picture of the inside of the urethra as it's been bulked. Right now we have a gel that we're using. We've got 7-year data on that. Generally response rate is around 75%. Historically, we were using things like collagen, some different like microspheres. Those success rates were 35%. So previously it was just a salvage procedure. Now with this being about a 75% fix, it's something that we definitely talk about more as primary management. The other thing that we frequently do here too is physical therapy. You know, I would say particularly in circumstances where I have mixed pictures of incontinence, physical therapy is really great. Now, physical therapy with stress incontinence is about a 50% response rate, where we'll talk about what it does with the others here in a sec. All right, urge incontinence. So, as I mentioned, physical therapy. This is probably my favorite thing to send people to physical therapy for. Reason is response rates are good. The other reason is, opposed to, like, say, option 2 there, I start a medication. You're a slave to the medication with the incontinence. If you don't take it, you start having incontinence, you're dealing with side effect issues, and you just have to continue it potentially indefinitely. Physical therapy is kind of more of an empowering process. I mean, you're physically doing something to control your bladder function and prevent the leakage. So it's something where people will come in and be very happy with that experience because they're doing something, they don't have medication side effects, and they can control what's happening. They don't feel like it's controlling them anymore. Now, when physical therapy and medication fail is when I have to start poking you with sharp objects. Okay, so first thing I have there is nerve stimulation. 3 basic ways I can do that. So the way that you see in the picture here, like that middle picture right here, is basically I'm putting a pacemaker with a wire that goes into the tailbone. And I don't know if you remember from my other urge incontinence slide with the little cartoon. The sacral nerve is what we're primarily impacting here. It changes some of that sensory input by sending a pulse signal there, and we can get your incontinence to improve. In a similar sense, we can actually stimulate a nerve down at your ankle that shares the same nerve roots as that sacral nerve, and in doing so, get your incontinence under better control. Now, it works better if we implant the wire straight there, but still, doing the tibial stimulation in the office with just an acupuncture needle, which is about once a week at first, is about a 60% response rate. There's a newer device where we actually implant a stimulator into the ankle. There's one that's about the size of a nickel. That's there for 3 to 4 years, and that has a response rate of about 75%. The sacral stimulator response rate's about 80%. Last thing you see over my head there is Botox. So I can go in with the camera straight into the bladder, take that, again, sharp pokey object, and inject the muscle with Botox. Botox is a paralytic. It basically partially paralyzes the muscle of the bladder, so it just can't have those uncontrolled spasms. And in doing so, gets the incontinence under control. That's another modality that has about an 80% response rate. Okay, and that's only the people that are doing the thing on the right and the left have failed medication, have failed physical therapy, and we're still seeing response rates like that. Now, there's one thing I got to do to break apart our response rates. One, that doesn't always mean dry, particularly when we're talking about urge incontinence. Urge incontinence, where it's not like a light switch fix as much, it's more of a process, and so with, the procedures like the nerve stimulation or the Botox, generally speaking, about 40% are dry, 40% are better, but not necessarily dry. All right, urinary retention. Now, this one is sometimes challenging. So when your bladder doesn't want to empty well, it could be either because the outlet is not relaxing enough to let the urine out, which could be pelvic floor muscles and sphincter muscle, or the muscle of the bladder itself is not contracting enough to get it empty. Okay? So physical therapy is one approach to handling this, particularly working on the outlet issues. Medications are one way of handling this, which are designed to help relax the actual sphincter muscle to make it easier to urinate. The other approach is the stimulator. Actually, I can put a stimulator in, and it could treat the urinary retention about 70% of the time. All right, and last thing here, take-home points in our little wrap-up. So first thing, incontinence is actually common, even though it's not talked about a lot. Okay, there's a lot of different causes for incontinence, and some of the whole process of doing this is figuring out what is contributing to the incontinence, and then item 3, what do we do to correct it? Because there's not just one approach. There's lots of different approaches we can take with any given type of incontinence. Again, it's not all about a surgical fix. I think that's a fear that a lot of people coming in to see me will sometimes have. No, I mean, we're frequently using medications, we're frequently using physical therapy. There's the ankle stimulator treatment. I mean, there's things that we definitely do that are not surgical to address this problem. You know, there's all the things that you can do that we discussed. And then lastly, the evaluation for this process is not overly cumbersome. I mean, usually from the first visit, there's some kind of idea about where are we going with this, what are we doing. We're not having to do a ton of invasive testing to figure out, put us on a direction. And the question is then, okay, once we start on that direction, how do you respond and where does it take us?